Okay. Thank you very much, Jennifer and Irene, for this invitation. And Øystein and I are, of course, very honored to be able to give this lecture. I will try and explain why these registers are important and how we can increase our knowledge. So this is one of my patients who has an Addison's disease and vitiligo, two autoimmune diseases, and this is how it all started. Another person who probably had the same disease was Jane Austen, who died early and wrote in a letter that she was black and white and every wrong color, who probably had vitiligo and Addison's disease in retrospect. So what we knew when we started was that autoantibodies was directed against the adrenal cortex, but not the medulla. And we were able, as Øystein said, to identify these as 21-hydroxylase autoantibodies. And it only took Endocrine Society 23 years to recommend this in clinical testing. And I think you as a patient organization, it's important to put pressure perhaps on us to implement advances in science and medicine much faster than this. So the reason then we started to get interested in APS-1 was the huge similarities between the common APS-2 and APS-1. And I will illustrate it with one thing, and that's premature ovarian insufficiency. When you have an autoimmune reaction directed against the gonads. And we were able, a year later then, to identify side chain cleavage enzyme in the adrenal and in the gonads as the autoantigen. So there are very good testing now for this. So the question then is, what to do? Can we treat this condition? And at the moment, we can't, but we can do one thing, and that's something we're doing with Addison, female Addison patients. If they have not had children, we screen them for the presence of side chain cleavage enzyme autoantibodies. And if they have such, we actually take ovarian tissue to cryopreserve. We still don't know whether it works or not, because none of the girls who have their ovarian tissue cryopreserved and has developed a premature ovarian failure have asked to get pregnant yet. I don't know if it's a deficiency of DHA or why, but so what to do with APS-1? In APS-1, it's much more common in females than in Addison's disease, and it usually starts quite early. So together with Professor Outi Hovata at Huddinge, we are starting a project now to cryopreserve ovarian tissue in prepubertal APS before the autoimmune attack occurs. And we also, I can report, have had 2 pregnancies in one patient who is after oocyte donation. So it's not impossible to get pregnant this way. So side chain cleavage enzyme is a good example of a very useful biomarker. But there are also other biomarkers, and Øystein has been instrumental in the identification of many of these. And Øystein and I, we have had a long and very fruitful scientific marriage, I would say. I hope that will continue. And for this rash that many of you have talked about, it might be one of the antigens that is already identified, histidine decarboxylase, but that remains to be proven. But to identify these markers that are clinically useful have been a very long and painstakingly, has taken a very long time. So we now have a new way to find what the immune system recognizes, and that is protein arrays. And I will show one example where we use this in a much faster way to understand what the immune system is reacting against. And it's Nils Landegren in my lab, who's an MD working full-time with this for 4 years now, who's been doing all the lab work. So what these arrays, you have human proteins that are made synthetically, one by one, and then printed one by one on these small arrays. And then you add your patient sera and your control sera, and then you see which proteins they react with. So it looks like this. And here I've shown the location of different known autoantigens, for example, dopa decarboxylase. And as you can see, you get a nice reactivity in the intensity of these antibodies. Likewise, tryptophan hydroxylase behaves the same way as does intrinsic factor. So the internal controls work beautifully. And then you easily get the perception that in sera from patients with APS-1 react against anything. But that's not at all true. So this shows all the different reactivities. And as you can see, it's only a small number of proteins that APS-1 patients react against. And if we enlarge this, we can see that the strongest 10 reactions are all against already known autoantigens. But what are these? And I will give one example. One of them, then a completely novel autoantigen, has the typical tissue distribution we almost always see when we see an autoantigen. It's only one tissue, in this case, the prostate, that the immune system reacts against. We still don't quite understand why the immune system, autoimmune diseases, show this kind of tissue specificity. The staining is only in prostate and not in tissues that, anatomically look the same. And the enzyme in question is transglutaminase 4. So the immune system reacts against this. And in celiac disease, you have a similar autoantigen, transglutaminase 2. It's only expressed in a few epithelial cells in the prostate. And it's in fact, to the best of our knowledge, the first gender-specific autoantigen. So it's only male APS-1 patients who react against this. Except this annoying patient, of course. And we retested and retested, and it was always positive. And it was a foreign patient, and I thought we had mixed up the first names, but it turned out she was indeed female. But when they looked in the medical record thoroughly, she had been treated with androgen for many years. This is a drug that is now discontinued, but you can still buy it online. And what happens is that, as already described in 1672, there is a female prostate. The periuteral glands of a woman histologically looks like a prepubertal male prostate. And if that female is treated with androgens, it becomes prostate tissue, and you can measure PSA in the blood. So we went back and looked at our male patients, and as you can see, the antibodies comes only after puberty. And we had 6 men with positive TGM4 antibodies, at 36, 28, 26, 32, 16 years, etc. But we had in our freezers a lot of consecutive sera. So we tested them. And as you can see, autoantibodies appear at puberty. And we also tested for other autoantibodies, and they don't appear at puberty. They come much earlier. So even if you have the defect, central defect in the thymus, you also need the presentation of the autoantigen. Then we took help of Mark Anderson in San Francisco. There is a mouse model, of course, of the disease with the same mutation as the patients. And here we were able to take biopsies from the prostate. And as you can see in the mouse model, they have an inflammation. So what about the autoantibodies in this disease? In normal mice, nothing. In female mice, nothing. And in male mice, all of them had strong autoantibodies. So we believe that this autoimmunity against this enzyme is the cause of the subfertility, or in some cases infertility, we see also in male APS-1 patients. And we believe that in this case we might have a treatment, because in mice that are knockout mice for TGM4 and don't have the enzyme, they become infertile, the male mice. So for the patient, we believe we can synthesize this recombinantly and use it as a treatment in case of infertility. But perhaps the most interesting part of this finding is that transglutaminase 4 is a member of a family of transglutaminase enzymes, where many of them are autoantigens in other diseases. As we said, transglutaminase 2 in celiac disease, transglutaminase 3 in dermatitis herpetiformis, etc. So we added APS-1 for 4, but we still wonder what these, is this orphan autoantigens? So if we look where these are expressed, they also have a tissue-specific expression. And transglutaminase 1 and 5 are only expressed in the skin. So we're currently looking for skin disorders that have these, but we still haven't found them. But we have, together with Mark Anderson and Tony Schum, found patients with lung disease that have antibodies against transglutaminase 7. But this disease remains to be characterized. I skipped that. So we have also a number of components of APS-1, as many of the speakers have spoken about. So I will just mention one of these, and that's malabsorption. We've been talking about that before. And we also have the endocrine. We have the, not to forget, the neuropsychiatric, very rare. And as Øystein mentioned, keratitis, alopecia, etc. And not to forget asplenia. That's important to detect in all patients with the ultrasound, because then you need vaccination for pneumococci, Haemophilus, etc. But let's go back to the malabsorption. And this is one of my patients who suddenly lost a lot of weight. As Øystein said, we were able, and then Øystein was in the lab and was instrumental in this finding. We found that the autoantigen was tryptophan hydroxylase. And if we take consecutive sections of a normal intestine, you can see on top the autoantibody reactivity, and on bottom the reactivity with an monoclonal antibody against serotonin. So what does the biopsies look like? As has been said, they have villi. The villi remain, so it doesn't look like celiac disease. But in the normal duodenum, you can see these enterochromaffine cells that produce serotonin. And in the APS-1 patient with malabsorption, they are completely absent. Is this the cause of malabsorption? Well, one evidence in that direction is actually if you have a rare congenital disorder where you have a mutation in a protein that leads to absence of serotonin producing enterochromaffine cells, you get exactly the same clinical picture, diarrhea and malabsorption. We also early on noticed that Paneth cells, there are autoantibodies against Paneth cells, and Paneth cells make defensins and lysosomes, which are a way for the immune system to defend us against bacteria. So together with Hans G. Bohmann's lab, and Hans G. Bohmann was the man who discovered defensins, we looked whether the autoantibodies were directed against this, but we were not able to show that. However, there's been a recent publication in gastroenterology that shows that there are indeed antibodies against alpha defensins. That's something that we cannot corroborate using our protein arrays, and that's something we have to look into further. So how should we treat this? And there has been a lot of reports using, as been said, quite a few different drugs. But that's anecdotal evidence that they work. And this is where you need a registry to do more controlled studies. I think this is one of the components of the disease where we really need a nice controlled study. We have opted for rituximab because it has almost no side effects, very few compared to the other medications. But once again, anecdotal evidence, and we need something much better. And I will skip in the interest of time, the hypertension, and talk about, as the last, what initiates autoimmunity. I think that's important, and that might also explain why patients with the same mutation in the same family might get such different phenotypic manifestations. So going back to this patient with Addison's disease, why do people develop autoimmunity? Well, one piece of evidence is that it's hereditary. This is another of my patients with Addison and psoriasis. He has a brother with autoimmune alopecia, a mother with type 1 diabetes and psoriasis, and he has an aunt with rheumatoid arthritis and a cousin with type 1 diabetes. And these are families we see all the time. And Addison's disease and type 1 diabetes were diseases that were deadly, usually before reproductive age. So why are these genes still there? And I think the reason is evolution inefficient? No, it isn't. This is a picture from an island close to my summer house in the Stockholm archipelago. And you can see, it's in Swedish, but you can see it's a guest harbor. It's where you can play bull, but it's also a cemetery for cholera cemetery. And this island in 1830 was an island then devoted to bury people who developed cholera. There was a big cholera epidemic. So it worked that way that you took your boat and rowed out to the island, and then you buried the people who had been there the week before, and you got buried yourself by the people who came the next week. Another example is the Black Plague in Sweden. Sweden has always recorded its citizens very carefully. So already in the 14th century in Gotland, we know that 70% of the population died. And in Uppland, where I come from, 7 out of 8 died from this disease, which is a bacterial disease that can be treated with penicillin. So the conclusion is that autoimmune responses are normal responses. So you've been selected, much as you have been selected to develop obesity, because to have obesity is good if you're starving. You've been selected to have a very active immune system. So if we go back to this and the 21 hydroxylase autoantibodies, we, together with Enzo Cerundolo, divided this enzyme. We try to understand why does the immune system select only one protein. There are thousands of proteins in the adrenal gland. And we could show that the responses of the T killer cells that destroy the adrenal is only against 2 small peptides. And these responses persist for many years. After an acute infection, they vanish from peripheral blood, but here they stay on year after year. So it's only these 2 peptides, 27 and 31, that are targeted. And the immune system, it's presented to the immune system by the transplantation antigens. And it's a short peptide, usually around 9 amino acids, that's presented. So we went back to the peptides to change the amino acid sequence, just 1 amino acid at a time. So within this adrenal gland with thousands of proteins, 1 protein is attacked, and within that protein, it's only 9 amino acids that's selected. So why is that? So we can say that all the T cells is only against 2 hotspots, 9 amino acids long, and the T cell response persists for many, many years. So our conclusion is that this is an old-fashioned theory back again, and it's molecular mimicry that might be responsible. That it's microorganism. It's a normal immune response against a microorganism that cross-reacts against the... So I think I take this in two steps here. When the T cell sees a peptide, if you look at the lower peptide, the leucine, isoleucine, alanine, tyrosine, leucine, lysine, etc., you have a T cell receptor that sees it. So it would be easy to say that you could look for those sequences in bacteria or viruses or fungi or parasites. But if you look in the upper, you can see there's a completely different sequence seen with the same affinity by the same T cell. So it will be very hard to find these putative microorganisms. But then we're collaborating with Michael Birnbaum that's devised a method to generate in yeast hybrids that express different peptides, random peptides. So using this, we can take a T cell from a patient and see, does it react with the peptide in the adrenal? And if so, which other peptides does it react with? So what we hope in the future, and this is not the near future, is to devise vaccination to prevent autoimmune disorders. If we were able to identify what kind of reactivity that initiates the autoimmune reaction, we might be able to induce vaccination against another part of the same microorganism, thus preventing disorders like Addison's disease and type 1 diabetes. So this is people in my lab, this is funding, and these are some of the people I'm collaborating with. Thank you very much.